Hello, this is not a spectacular case that I'm going to present today, but quite a common patient at an orthopedic clinic. This is a patient I met last week, 65-year-old I think woman, pain from her shoulder for about 10 years. Gotten a little bit worse from indirect trauma to the shoulder. She was lifting a kind of a heavy thing for a few weeks back, but as stated, she had a lot of shoulder problems even prior to this. And on the referral, the question was rotator cuff tear, ? And just by looking at her x-ray, we can say that yes, she has a rotator cuff tear, and probably a massive one. And why do I say that? If we put some drawings on that, we look at the acromio-humeral distance, which is almost none in this case. The humeral head is right up towards the undersurface of the acromion. And you can also look down here, the inferior margin of the scapula and the inferior margin of the humerus and humeral head is supposed to form this arch that is called the Maloney's line. So this is disrupted in this case. The humerus is way up there. So this tells us that she has a massive rotator cuff tear involving more than one tendon. And if we look at the same thing with ultrasound, we can see here the acromion. We can see that the humeral head is just up towards the undersurface of the acromion, and here is the deltoid muscle. So if we ask the patient here to do an abduction, this is what it looks like. It is now the deltoid that is elevating the arm, not the rotator cuff, and we can also see that the humeral head is scratching towards the undersurface of the acromion. And if we look in the short axis view, this is anterior, this is posterior. We can see that there is no remaining rotator cuff, no supraspinatus, no infraspinatus. So this is what we call naked head. Here we have the deltoid muscle, here we have subcutaneous fat, and here we have the skin. Yeah, and looking at this image, this information we kind of already know without looking with ultrasound, that this remaining tendon and muscle from the torn tendons are in bad shape. If we look at the infraspinatus, it is hyperechoic, there is no fibrilled pattern, and it is atrophied. Same thing with the supraspinatus, and if we just look at the borders here, this is the supraspinatus. This triangular shaped thing is a fat pad, and here we have the overlying trapezius, and again the subcutaneous fat, this area, and the skin. And what do we do with these patients? In this case, she had a lot of pain at night, pain at rest, so I gave her a corticosteroid injection. And coming here from the posterolateral part, okay, we had some sound on there. Yeah, there is the needle, and yeah, we can stop that and go to this video instead. There is the needle coming from the posterolateral direction, and you just go towards the humeral head since there is no rotator cuff, and this is also an intra-articular injection actually, because there is no rotator cuff, so there is an open communication down to the joint, and the fluid just disappears into this void. And after that we refer the patient to a physiotherapist, and that starts up the patient with trying to restore the range of motion and deltoid strengthening training according to Levy, so a progressive loading of that. So time, patience, and exercises like this. And if the patient still does not improve, they have a lot of problems in everyday life, a lot of remaining pain, etc., I will make an appointment for the orthopedic surgeon, and they will discuss if a reversed shoulder replacement would be an option for the patient. So these were some thoughts on a patient with a massive rotator cuff tear, and of course there are a lot of other issues and topics that need to be discussed in cases like this. For example, where do we from an image perspective draw the line and say to the orthopedic surgeon that this rotator cuff is probably irreparable from an image perspective? Super important questions that we go much more into detail about on our courses. So if you have found this interesting, check me out on Instagram and also check out the website. But you are of course more than welcome to join one of our physical courses, and there is still time to make it to the Copenhagen course in the end of September. But otherwise I hope to see you in Stockholm, Sweden in December. Thank you. Take care.